Hey, hello everyone. As Sonali mentioned, I am the Performance and Planning Analytics Manager for the Kenton Medway Integrated Care Board. I'm one of three Performance and Planning Analytics Managers, and we are responsible for distinct areas. My areas are elective recovery, and that covers everything from outpatient transformation, diagnostics. There is a dedicated cancer analyst, but I do a bit of overseeing in regards to things like the planning around for that. And I've also just taken on the learning disabilities and autism programme. Sort of like the main things I do is relationship building. As you'll probably see as we go along, one of my main things is not necessarily the very technical sphere of analytics, but the really understanding the nitty-gritty of it and understanding the context and what does it mean. You can't just look at certain metrics in isolation. You need to be able to understand what they mean. I'm one of the second leads for the overall plan submissions for the system, and I do quite a lot of database and dashboard creation and also board report creation. I have also just taken on a voluntary role for the branch lead for AFA, which is the Association of Professional Healthcare Analysts, for the South East branch. My main background is in acute contracts, performance planning and data. I absolutely love learning and development. If I'm not trying to push myself or doing some kind of continued professional development, I feel like I'm just not doing enough. I completed my healthcare management masters at the University of Kent in 2022, and I did my dissertation on recovery in Kent and Medway. And as part of that, I used both qualitative and quantitative analytics techniques. And it allowed me to interview quite a lot of people around the system and also increase my knowledge in regards to my day job as well, and also build those relationships I needed. I've worked in the NHS since 2015, and I've had over 14 years experience as an analyst in various industries, including pharmaceuticals, HR, engineering, and also the NHS. My timeline is probably more all over the place than maybe someone normal would go to. I didn't particularly feel like I had a calling earlier on. I liked maths, I liked statistics, but I didn't really have a lot of sort of guidance regarding what that could realistically lead me to that wasn't something more, say, educational. So the A levels I did was maths, ICT, and government and politics. At the time, I thought I'd probably quite like to do a law degree. I think I'd just probably watched too many law programs and thought that looked like fun. Didn't quite work out in that respect, and I sort of changed my mind a little bit. I then decided to work for a few years after my A levels, and I became a recruitment consultant for social workers, which was quite a fun time. Got to work in London, got to work in Liverpool Street, got to make quite good connections and friends. I then decided I did want to go to university and do an undergrad, and at the time I would have been quite interested to do something like a statistical degree. However, a computer science degree was more relevant at that time for something that I wanted to do. So at the time I thought, actually, I'd quite like to be an analyst. So let's see if the computer science degree would get me there. So I did the computer science degree. It was a lot more programming than I'd probably liked. I really enjoyed the first year. It had a lot of logic in it, but then it focused a lot on things like coding in Java. I did enjoy the database programming in SQL, so it kind of ties into what we're doing now, but it wasn't exactly what I wanted to do. After I graduated, I was very lucky to get a graduate placement in a pharmaceutical company, and I worked there for a couple of years before I moved into a HR analytics role. And then I moved from that. I mainly moved because I moved locations and I couldn't keep commuting to places like Cambridge from Kent. And then, and also traffic. So then I moved into engineering, and I found it to be quite a misogynistic culture. And so at the time, my sister-in-law was working in the NHS, and if anyone knows the NHS like I do, it's quite incestuous. Sort of people you know are also potentially family members or close friends. So she sent me a few links to a few jobs that I might be interested in, and I just thought, right, I'll just apply for everything and anything analytics wise within the NHS, and I got offered two roles, and I took the higher banded one. So I started out as a performance intelligence and system development analyst for Medway Clinical Commissioning Group in November 2015. And then we did a bit of a reorganisation, and we ended up trooping over to DGS CCG. And there I was a performance and planning analyst. And I'll just mention now, nothing comes particularly easy to me. I have to work very, very hard for what I've got and where I've got now. So I work very hard. And after a couple of years of doing that, I was put up for rebanding to the next band. So I had an internal promotion, which was great. And then COVID happened, which was not so great. But it also gave me that sort of decision-making process where actually I do quite like talking to people, and I could go days during the lockdown and not talk to anybody within the organisation or friends or family. And so I decided it was about the right time to do my master's. So I decided that I wanted to do a healthcare management master's. I wanted to expand my knowledge, not just of the analytics techniques or statistical techniques or things like SQL or Power BI. I wanted to know actually what is the context around it, what is going on, what are the main themes at the moment, and I wanted more of a sort of software intelligence education in that regard. Throughout, I'd go on as many continuing professional development courses as possible, not just SQL, not just Power BI, previously done Excel, Access, things like presentation skills, confidence skills, that kind of thing. And within our sort of healthcare analyst industry, there's not been a lot of sort of development guidance for us, whereas you have areas like finance, and you have their accreditation, you have their qualifications, they have set up networking events at the moment. There wasn't really anything specifically for analysts. However, in recent years, the Association of Professional Healthcare Analysts has been set up, and they've worked conjointly with NHS England to set up things like the competency framework to give us a guide of, okay, at this level, you should be doing X, Y, and Z. And if you're not doing this at this level, then here are the resources that could get you to this level. And they also offer things like mentorship and networking events. So when a call went out for a Southeast branch lead, I put my hands up and said, yeah, I'd really love to do that, not just sort of like for my own benefit, but I'm really keen to like develop my team as well and make sure everybody is pushing forward. So that's kind of sort of where I am at the moment. Okay, so some of my most recent activities has been about developing myself and developing others. So I'm the development lead within our whole team at the moment because I took on the AFA lead role. It's given me some great opportunities this year to, well, last year, to go to a number of different conferences, which is something really new, because up until we had our new chief analytical officer, we pretty much believed that we weren't allowed to go anywhere or do anything. So it's been absolutely amazing having him. Got to work on the stands and talk to people and try and get people on board with it. I've managed quite a lot of achievements in that respect, and I was also put forward to speak on an elective recovery panel at the HSJ Health and Care Intelligence Congress in December, which was very, very scary. But I found that I did lead the discussion quite a lot, and I seemed to know, well, I held my own basically, which was really nice to know. Okay, so I'm not trying to do a sales pitch here, but this is sort of the most exciting part of my role at the moment. So a lot of what I've done with the as the branch lead of South East, I've had a few achievements there at the moment. I've increased membership from 0 to over 50 in 2 months, and that's primarily between convincing our executives for corporate membership, and we've done that for the Integrated Care Board. So all analysts within the Integrated Care Board are now members of AFA, and Medway Council are all members of AFA, and Maidstone and Tunbridge Wells are at the moment raising their purchase order to get all of their staff members. And then we also have a quote out with East Kent at the moment. So because of their financial difficulties at the moment, that's going to be a bit different. But that's a real massive achievement. And we've also managed to get people 3-year membership instead of 1-year membership. So that's pretty much never been done before. And there are some branches in the country that have been running for a few years now and have about the same amount of membership. So we've done really, really well to get people engaged in it. I personally have also gained the AFA CEO as my mentor, which is absolutely fantastic from my point of view. Not having a sort of structure and development structure, it's very easy to just sort of not necessarily go off on a tangent, but you just don't have that support network around you that says, if you do X, you'll get to Y position. So, but now we're starting to have that structure around it. So he's going to sponsor me through my accreditation, which is great. I've also managed to recruit 2 co-leads from around the systems. So we've got Lou Palace from Eckhoft and Natalie Goldring from Medway Council. So what we're looking for is making sure that our branch of the South East is an inclusive branch, and it crosses over from the Integrated Care Board to different providers and also to Council on Public Health. What we're also trying to do is set up regional networking events for members. So what we're looking at is going into London, and all analysts from across the region will be able to go in, have a drink and talk to people. What I found was really nice was that talking to people, there are the same issues across the country, so you get that feeling that you're not alone. Whereas I think the way some analysts work is we tend to work a little bit in silos, and you don't necessarily have those conversations with your peers. So it's really nice to have that network set up for us. Okay, so my roadmap for the future is basically I'm never ever going to sit still with any of this. I push on, I push forward, I work really, really hard. I try and get my staff to work forward as well. I'd like to keep them motivated. We're just about to start an internal team reorganisation. As mentioned before, we have recently got our own chief analytics officer, which is really, really exciting for us at the moment because we actually have somebody leading us that knows where we're going. So it's actually already given us that sort of development opportunity that we didn't have before, and also again recognition within the Integrated Care Board that we didn't have before. We're going to continue developing the South East branch of AFA. In conjunction with NHSE, AFA has also adopted the National Competency Framework, which we're all going to be working through and developing to. And there's now clear sort of specific roles for data analysts, data engineers and data scientists, and it is a really, really exciting time if anybody does want to get into sort of analytics sphere at the moment. Actually getting in is a lot clearer than it ever used to be. There's a lot of development opportunities. We have something like 15,000 analysts within the UK, and it is an industry that is set to grow despite cuts within the NHS. So we will only ever need more analysts than less. And then the aim is to get professionally registered with the Federation for Informatics Professionals, and to really, really turn what we do into a recognised profession, and also be taking part in the Skills Development Network steering group. So all of the different systems. So we're looking at sort of like the Medway integrated care system. We're looking at AFA South East. We're looking at Skills Development Network, and to really tie everything in together so that we have a proper holistic offering to our analytics staff. So that's really exciting coming up as well. Okay, I'd just like to give a few examples of some of the work I've been doing. I think a lot of you are sort of on the diagnostics side, so I've focused on some of the diagnostics work. What I have used in some of them is the DMO one, which is a publicly available data source, so it shouldn't be confidential. Where something is confidential, I have crossed it out, so I will just go through those quickly as an example. So as an example, we use SPC charts, and you'll see from the top one, it's showing a special cause improvement, and you'll see from the bottom one, it's showing a special cause concern. So recently, only the top one was being included in our board report. So it was making diagnostics look like there was nothing wrong. However, a lot of the talk around the system is that, okay, there's a lot of issues with our 6-week wait standards, but everything that was going into the board report was saying how fabulous it was, how great it was. We're far exceeding the 120% target for against the 1920 financial year. So eventually they came and spoke to me and said, well, okay, what you need to do is you need to balance it out with looking at the total waiting list growth and also the 6-week wait standard. So the top graph here is the total activity, which is showing a nice increase, which is what we want. However, what we also see from the second graph is that our waiting lists are increasing substantially. And the little red dotted line is where it was in 1920. So there is quite a significant difference in where we are and what we're supposed to be getting back to. We're supposed to be getting back to 1920, but at the moment, it's just not particularly feasible for our systems. So one metric should not be looked at in isolation, and you also have to know that you can't just present something and not understand the context around it. Otherwise, I think there's a few comments that, well, you can use statistics and data for evil purposes, and it depends how you present it. And that is very, very true. And people should definitely be aware of that and know the bigger picture. And as analysts, it's our responsibility to make sure it goes out. So looking at the 6-week wait compliance is one of the biggest issues within diagnostics at the moment. I run weekly and monthly reports, so this is showing where we currently are in regards to the 6-week wait standard for one of our providers, and this uses the nationally available DMO1 data. So you'll see on it there's the 95% target, where 95% of patients 95% of patients should be seen within 6 weeks. You'll see the trajectory was reevaluated in April and in October, and that's currently the provider is actually overachieving their trajectory, which is great. However, it is still below the national target. So what do? We look at that with our providers. Commissioners have conversations. They use this to start those kind of conversations. And so what we can see in the table below is, okay, you can't just look at diagnostics as a whole, you need to look at it at modality level and group by modality because they all follow completely different pathways. So the main issue at this provider with compliance is endoscopy. And then the second main issue with compliance is DEXA echo and audiology. So within our system, we have an endoscopy working group has been set up, and there's a strategy. Okay. And you'll have to ignore the cross because this is not publicly available. One of the most interesting bits of work I've done this year is inequalities analysis on the diagnostic waiting times. So it's looking at whether certain sections of the population are more or less likely to wait longer for their diagnostics tests. So this could be any kind of like imaging modality, physiological measurement, or endoscopy. And because I've been working with diagnostics for a long time, I immediately knew that you can't just group all of diagnostics into one cohort. They needed to be split out. Again, the pathways are completely different. And when I did do it overall as well, but you find that there's not a lot of insight you can get. So the segmentation we used was looking at patients on the cancer PTL, patients within imaging, patients within endoscopy, and patients within physiological modalities. We also looked at the data quality, and we did a consistent methodology for each of them. And the results were then presented to the diagnostics board and also the health inequalities subcommittee. And the findings are now with providers to replicate to see if, using their data, which is more granular, they identify the same issues. So, for example, we've used funnel charts, and anything above the upper control limits, those patients are more likely to wait longer. So those circles in red indicate that those patients could experience longer waiting times than others, or they're more likely to experience longer waiting times than others. And the circle in green, those patients within those ethnicities are less likely to wait longer. So it's quite an interesting piece of work. It's about overall a sort of 100-page presentation. So this is only a little bit of a snapshot what we did, but it allowed us to apply different statistical techniques and to do real investigations and present real findings, and it was a great development opportunity for us. And that's about the end of it at the moment.